Okay, well, I was going to do a talk on imaging, but this is a talk which integrates some imaging into the sort of general theme. But I'm talking about CHIP patients and hemodynamic support. So this type of high-risk case that we've just seen, certainly in the context of somebody in this situation with significant LV dysfunction, with lemur-dependent circulation, that there are indications for left ventricular hemodynamic support. What we're seeing in these increasingly complex cases, anatomically complex, also with high surgical risk, these are the patients that we're now being seen or increasingly asked to treat by our surgical colleagues, patients who are really unsuitable for coronary artery bypass surgery, either because of patient sort of cofactors, but also because of the actual incredible procedural risk. Now, these were the sort of original type of CHIP case that most people, I think, without the availability of LV support, somebody with very poor LV function, well, they would do these cases without left ventricular support in position. In the US, I think the market has become very distorted because these cases are now reimbursed, and so there is a big incentive, reverse incentive, to do these cases. However, I think we need to be looking at the patients in a bit more detail to understand what are the reasons for selecting patients for LV support in whom we're considering complete revascularization. The device that we're using predominantly is Impeller, and now the Impeller CP, very easy to insert. But perhaps in the current sort of day and age, would you really need LV support? There is a possibility that this patient with this type of lesion will decompensate during the procedure. How are we going to support them? Well, is it going to be inotropes and cardiopulmonary massage, or will it be an Impeller? Impeller certainly does take out the stress and does allow you to achieve these really nice results in the left main, able to achieve complete revascularization in a hemodynamically sort of safe environment. So when we're thinking about these patients, the highest risk cases often have the greatest incremental mortality benefit from treatment. So these very high risk cases, often the surgical turn down patients, they are the least desirable to treat based on their absolute mortality, but they do have the most to gain. And so as part of the development of complex PCI techniques in conjunction with LV support expertise and the availability of devices which provide sufficient power output, these various algorithms of how we select patients have evolved. So this is something from Jamie McCabe from University of Washington. Again, this idea of categorizing patients as you don't need support, you do need support, in certain circumstances, and you should strongly consider support up front, a sort of traffic light system. Now, we've not been talking about, this is simple, low-risk interventional procedures, you can call it SLIP if you want, but really what we're dealing with in the CTO world is CHIP, complete revascularization for high-risk indicated patients, which include all this complex multi-vessel disease, bifurcations, left main stem, heavy calcium burden. So we've had examples of all of that, so of these cases on this course. We haven't done any LV support here, but really the most complex aspect of this remains CTO. So it's in fact going to be the CTO operators which are really providing the sort of direction and the ability to do all of these complex cases. So this is a case that James did with me a couple of 2 or 3 years ago, which is somebody who was stuck on the intensive care unit in pulmonary edema and came and had their left main opened acutely, but they were left with this. There was an occlusion you can't see of the osteal part of the circumflex. The right coronary is occluded, you can see all this cross-filling, and this patient is stuck, hemodynamically compromised, a CTO of the right, left main stem, circumflex LAD needs some attention. Now this is the high-risk CTO pathway, looking at whether or not some would be suitable for left ventricular support, which we've divided into these three aspects: left ventricular function, CTO anatomy, and the patient factors. And you can see the degree of EF, which will give you the maximum score. So if your EF is less than 20, it gives you 3 points. With multivessel disease, left main disease, and the CTO gets you 2 points. Pulmonary edema over 75 gets another 2 points. So this is somebody, if you're going to do an intervention, then you would be well advised, if it's available, to use LV support. It will make it a simpler procedure. And achieving here complete revascularization, a retrograde knuckle, reverse cart in the proximal segment, we've seen so elegantly done just now by James and Colin, and then fixing the left main. Here's another patient, slightly less risky LV, but so gets a score of 5 again, would mandate using LV support, using this algorithm. And this was somebody with a dominant circumflex system, left main trifurcation with reduced LV function. It's got heavy calcification, left main disease, with somebody who would probably previously require rotational atherectomy. But you'd be, preferably, if you've got a way of maintaining wire position, then you can treat this left main trifurcation. In this case, this was with the first generation shockwave, which we spoke about this morning. And I've been routinely using OCT to look for the efficacy of the shockwave treatment, but also in guiding left main interventions, similar to the case that you've just seen from Colin. And I would say that in this situation, poor LV, this type of left main anatomy, that this very high precision approach with OCT is certainly feasible to do, and I think gives you as much information as IVUS. So here we are, left main stent expansion, looking at the deployment of the stent in the AV circumflex. Get lots of information from OCT, and so this is a complex intervention done with LV support with OCT optimization. And you can use all the fancy tools to show that your stents are opposed. You can check all the side branches. You can fly down through the vessel, and you can really be confident that you've delivered a good result. So a complex patient with high precision PCI done with OCT. This is a case that was done on one of our complete Revasc courses, a very complex patient, young male patient, tragically paralysed in a road traffic accident. LV function poor, multiple CTOs, in fact previously turned down for a heart transplant, had attempts to open the LAD but became hemodynamically unstable, and this is a case done by Tony DiMartini. Again, if you plug that into this sort of risk algorithm, high-risk CTO pathway, EF poor, you've got multiple CTOs, get 2 points for that, and so it gets a score here of 6. This is the left ventricular support device going in, and quite tricky anatomy here. So right ventricular marginal branch occlusion point for the right CTO, which is cross-filling the LAD, which you'll see is occluded there proximally, and then the distal LAD, septal collaterals are actually cross-filling the distal right, and there's also a circumflex occlusion. So all this done in an environment where the patient remains hemodynamically stable because they're supported with left ventricular support device. Right coronary artery CTO had to be done retrogradely, recanalized successfully, retrograde there, then the wire in the antegrade LAD. OCT in this case was used for sizing and optimization. So this is, we knew that this was an antegrade wire escalation in the LAD, so there was a high degree of confidence of using contrast injection. but you get all the information. You get a very nice picture of the LAD before stenting. If this had been a dissection re-entry case, we would not have done an OCT beforehand. So, but I think with antegrade wire escalation, then I think it's perfectly legitimate to do so. And all the measurements of the left main and the distal vessel, distal target, are all available from this first OCT image. So this is the result that you end up with in a very hemodynamically compromised patient, supported with an impeller, refashioned left main, similar to the case we've just seen, fully optimized with OCT. So we see the stent here satisfactorily deployed. There's an area of underexpansion here which would need to be dealt with. But really you've got very nice imaging throughout the length of this lesion. So this was a very complex patient with hemodynamic compromise, turned down for surgery, done successfully with multi-vessel CTO treatment on an impeller with OCT optimization. What about even more complex patients, if there are more complex patients? Well, lots of structural heart disease. And in fact, I think we have to a degree neglected dealing with the coronaries as well as they should be done in patients with severe aortic stenosis, but also with concomitant severe and complex coronary disease. And we now have the tools to do that, both in form of left ventricular support and also with image optimization. So this is an aortic stenotic patient going through the protected PCI pathway, poor LV, all this anatomical concerns, and elderly patient. This is the coronary angiogram showing there's actually a very tight osteocalcific circumflex disease. So you can't actually even engage the coronary artery. Echocardiographically, severe aortic stenosis and significant LV dysfunction. So how do you deal with complex coronary anatomy in this context in somebody who's got a hard indication for aortic valve replacement as well as revascularization, not a surgical candidate? So this is a sentinel device going in. So the sentinel device goes in because not a very nice aorta, big stroke risk with these hostile aortas with both impellers and with TAVI devices. So sentinel going in via the right radial. I think we're probably going to be using this increasingly commonly. Crossing the valve, obviously this is a highly technical procedure. It takes about 3 TAVI operators to cross the valve. And then balloon aortic valvuloplasty done. So once that's done, we can then, this ventricle is a struggling ventricle. You can immediately then put an impeller device in. Now there are groups in the US that are actually doing the BAV alongside putting the impeller device. They're doing it at the same time. So once you've dealt with your aortic valve initially, you've got your left ventricular support in place, you're then using, in this case, undilatable balloons. We're using intravascular lithotripsy. So we're able to set to work on the coronaries, using all the techniques that I think really have largely come from the CTO community. Lots of work with guideliner, lots of work now with intravascular lithotripsy. We're able to re-establish flow in the LAD, all under percutaneous LV support with an impeller. Quite a nice result from somebody who had very little coronary circulation. Those of you who are TAVI operators, just watch. I think this is quite good positioning. Anything wrong here? So up until this point, I'd been doing the case, and then the TAVI specialist came in and did this. Apparently that's not good. It's moved a little bit. Not quite sure why it moved. What would you do in this situation? Another valve?
I mean, it depends where the valve ended. It looks like it got
apparently quite severe. There was quite severe aortic regurgitation at this point. So, in fact, that's exactly, I think, what they did. So, a second tabby, getting that into position. So, this looks to be the right position.
Are they expensive, those valves?
Apparently, yeah. Yeah, watch. Anyhow, how hard can it be? Anyhow, so little, no, not a third one. So then there was some post-dilatation done, and the aortic regurgitation seemed to be not that bad. Anyhow, the patient did relatively well. Here's another case. Nasty coronaries, nasty left main, but no aortic stenosis this time, but unfortunately the aorta was occluded. So severe LV dysfunction with those coronaries. How are you going to treat this? Well, consider for surgical revascularization, but very poor conduits. So the surgeons asked us whether we would be able to help. So this is the insertion of an axillary impeller device. And here you can see the impeller coming around the corner, crossing over into the chest cavity from the axilla, and then into position. So this is an interposition graft so that you'll need the help of the vascular surgeons or your cardiothoracic surgeons to put that graft in. And then you can then set to work on the coronaries, refashion all of the coronaries. Left main needs intravascular lithotripsy. So lots of lithotripsy. Very significantly dissected coronaries. You can see all this. We weren't taking too many pictures, but certainly there we were exacerbating the hydraulic dissections here. Stents going in. Spending our time, like we've just seen, column refashioning that left main. Dual lumen catheters being used. Interestingly, during this type of case, in somebody with this degree of left ventricular compromise, and we're seeing this, fairly frequently now, we do get a loss of pulsatility in the aortic pressure. So you're actually doing these cases with patients often with a completely flat blood pressure in the 70s and 80s sometimes. But you go from this really, this is a really nice result, fully image optimized. So going from this to this, and facilitated by percutaneous LV support and all of the adjunct tools that we've seen being used. So at the moment, I think we've got impeller as the current gold standard in chip PCI. It's easy to use with more support compared to a balloon pump. It's protective of the heart during the intervention itself and can be used in the recovery time. There is good evidence accumulating that it's also renal protective. The randomized trial data is very poor. The PROTECT 2 study, I think, didn't really reflect the level of complexity that we see today, but there is a consistent message across multiple registries that it's useful. It's a key enabling technology for these complex chip patients, often including the treatment of patients with CTOs. And I think the guidelines in Europe are going to be changing quite soon and will support more widespread use. Thank you.